welcome to my tutorial on the chest x-ray. Alright, so in terms of chest x-ray, some of the most important things that you should be aware of is that even though the patient is unwell, sometimes they actually might have a normal chest x-ray. And for whatever reason, it could just be because whatever's causing them grief hasn't actually manifested in the chest yet. So don't be deceived and don't be surprised if the patient comes back in a day or two and then suddenly their chest x-ray is no longer normal. The quality of the x-ray is very, very important. You can deceive people and you can deceive yourself if you present a chest x-ray that is abnormal when in fact it's actually due to the image quality. So your density, your contrast, rotation, tilt, etc. isn't very good. So just make sure that before you send off a picture, have you produced an image that is suboptimal to begin with, which can mimic pathology. A fine example is the AP chest. Lots of people produce images that are oftentimes quite undiagnostic and frankly probably should have had a bit more forethought to it. Inadequate inspiration effort can mimic lower lung changes, be mindful of that. And if you do a lateral decubitus x-ray, this will change the appearance of air fluid levels in the sense that if you lay them on the left, it looks different to when you lay them on the right. So just be mindful of that as well. So when will you do a lateral decubitus x-ray, chest x-ray? One of the only real reasons why you would is, for example, if the patient has gone to surgery and has had a lot of abdominal, posterior, back, buttock, leg surgery where they physically cannot sit up or lay supine. And in that instance, we could do a lateral decubitus x-ray to do a line check. These images can actually be quite good, but you need to make sure that you give yourself the best opportunity. So arms out of the way, making sure that the patient, if they can't lay flat or can't sit up, they're fully on their side to not introduce another angle. So if you are doing lateral decubitus, make sure the patient is fully on their side and you note which side is up because that does change how the air fluid appears. And the next tip is to remember the patient. Every patient is different and sometimes the pathology that you are seeing might actually be perfectly normal for that patient. So, you know, that little bit of a bump there, is that normal, new, old, etc. And that brings me to the next point. Always look at old films because a lung mass that hasn't changed in many years is probably not lung cancer. Things develop, our bodies change. It could be iatrogenic. In other words, it may not have a cause. So just be mindful of that as well. All right, so this particular presentation isn't really about critiquing, but just giving you some different things to think about when you look at a chest x-ray. So the diaphragm is a very good spot to look at, and it's often a place that students don't understand very well. If you have a look at this diaphragm, can you see how the blue line there, which is this line here, goes from the posterior edge all the way to the anterior edge? This is usually, if not always, the right diaphragm. The reason why this is the right diaphragm is because this one is always the left diaphragm, because the left diaphragm silhouettes with the heart. So by silhouetting, I mean the actual diaphragm comes into close contact with the heart at the anterior surface here, which means on radiographically we are unable to differentiate it because there is no air soft tissue interface. The right diaphragm is usually a lot taller, a lot higher than the other diaphragm, so that's another indication that this blue line is the right diaphragm. So when you're looking at the lateral, have a look to see which one is a diaphragm by checking which one stops suddenly. That stops suddenly will mean that's probably the left diaphragm. On the lateral, that's another good way of identifying which way to rotate the patient if you need to repeat. Obviously, because you can identify the diaphragms, you know which one is more anterior, which one is more posterior, etc. So you can see here clearly that, again, the blue line is the right diaphragm and the red line is the left diaphragm. The hilar region is a collection of blood vessels and the main bronchus. The posterior and the inferior hilar region is often a lot thicker. If the superior region is more prominent or becoming quite enlarged in comparison to the patient's old films, or it just generally looks a lot larger than it should be, that's a good sign of pulmonary edema, where pulmonary fluid has accumulated inside the pulmonary veins, and because of backflow, it has flowed up into the blood vessels, and it goes everywhere. So an indication of early pulmonary edema is upper hilar region enlargement. This big vessel here is the pulmonary arteries, can be pulmonary veins. It is literally impossible to differentiate, and likewise the same with the other side. Like I mentioned here, you need to be very careful of identifying the vessels. You can see the red line here is a nice hilar border, so this is like a blood vessel, and then this border here is the right cardiac border. If you compare it to this side, can you see how there's an absence of a nice border? This is pathology. That's why you need to identify what is normal to be able to identify what is abnormal. So one of the first things that I encourage you to do is just have a good look at normal chest x-rays and see what you would expect. Hopefully you would have realized that there is no heart border here. So whatever this pathology is, it has silhouetted with the heart border. And this is a classic indication of usually right middle lobe collapse. And we'll go through some examples in a second where you can hopefully improve your understanding of the silhouette sign and also how lobes can collapse, causing this appearance. All right, but before we do that, we need to mention a couple of common variants that can trick you a little bit. The azygos lobe, the azygos vein can become quite prominent, causing a separation of your upper right lobe into a smaller azygos lobe, as it's termed. And so you have this little bit of a fissure line thing here. It can sometimes mimic upper lobe collapse. So that was the azygos lobe description. The other common variant is pectus excavatum. Pectus excavatum is, as you probably know, is a abnormality of the chest wall that some patients have, and usually in tall men. And because of the excavatum itself, it can actually obscurate the right heart border. So this is actually quite normal. The patient doesn't actually have any pathology per se. However, they do have pectus excavatum, so just be mindful of that. So before we do the silhouette sign, I would like to remind you of the difference between a mediastinal lesion and a chest lesion. Our goal is to always determine if the mediastinal mass is localized to the mediastinum or localized within the mediastinum. So what that means is it next to the mediastinum or is it inside the mediastinum? So if you imagine your thorax as, I guess, like a loaf of bread, is the lesion in the bag that surrounds the loaf of bread, or is the lesion in the loaf of bread itself? That's very important to distinguish because it does change the prognosis a little bit. Often in textbooks and on Radiopedia, it describes the mediastinum as compartments, the anterior, middle, and posterior mediastinal compartments. And depending on where the lesion is, it actually may help you have a differential. So a common mnemonic that I like to teach you guys is the anterior mediastinal mass, and that is the 5Ts. So the 5Ts often is a mnemonic that we use to provide a differential for an anterior mediastinal mass. And I think later I do have a slide on that as well. True mediastinal lesions will not contain air. In other words, this lesion is not in the lung that is abutting the mediastinum. It's purely inside our loaf of bread, as the analogy there. A lung mass or can abut the mediastinal surface, so it can be inside our bag, touching our loaf of bread, but not in the loaf of bread. All right, so the silhouette sign now. So the silhouette sign is essentially this. So any particular pathology that resembles in terms of density similar to that of the surrounding mediastinum, the heart, will cause that particular border to be obturated or obscurated. What I mean by that is, for example, if the right middle lobe collapses due to the push and pull effect of the chest, it pulls the right middle lobe towards the heart, and so this particular border you often lose this particular border. Similarly, the left upper lobe, if that collapses, it often gets pulled towards the aortic knuckle here. The lingua or the left lower lobe can get pulled as well, obviously, and it gets pulled towards the heart. But because it's mainly attached at the posterior border, it might appear as if the patient has an enlarged aorta. So you can imagine that getting pulled that way, and there'll be some actual examples very shortly. So just be mindful of this when you look at the pathology. By knowing where the pathology silhouettes with the cardiac border will help you identify its actual location and to be a bit more knowledgeable as well. So this is my schematic of the right chest x-ray lateral, I guess. It just puts in perspective the position of the upper lobes, the lower lobes, and the right middle lobe on the right side. So you can see there that the right upper lobe is a very superior structure, and it really only abuts I guess in a way, it only abuts the superior heart borders. The right middle lobe, as you can clearly see there, abuts pretty much the entire heart. So because of that, when it collapses, it gets pulled quite close to the entire right heart border. The right lower lobe, because it's very posterior, gets pulled and dragged to the bottom and posteriorly. All right, some examples now. So hopefully you can appreciate there that the right heart has this opacity. We might describe it as a fuzzy white, predominantly located in the right upper lobe. It silhouettes with the superior mediastinum, so this would suggest to me that this patient has a right upper lobe pathology. And then you can see there on the lateral view the actual fissure there, and you can see the actual condensed lung here. So for whatever reason, the lung has collapsed, so it's pulling the lung towards itself. Now at the moment there's no pneumoperitoneum, none of that kind of stuff. Sorry, there's no pneumothorax, none of that kind of stuff. So the lung is just opaque and white at the top here. This is an example of a right middle lobe pathology. This is not a very striking example of it, and this particular I guess density And this is what the radiologists often describe it as a density increase. Sometimes it's hard to identify exactly what it is, but this is a density increase. And this density increase sits right next to the heart border here. So this is actually a small example of a right middle lobe collapse. And hopefully you can appreciate with my schematic here that triangular opacity sits right on the oblique fissure and the horizontal fissure there as well. And I do apologize. I think I called that the superior fissure before, but that's actually the horizontal fissure. Moving on to the next slide. Hopefully you can see the pathology there. The right heart border is very, I guess in a way, it's obliviated completely. It's just not there. The diaphragm itself, you've lost the contour of the right diaphragm there. So this is clearly a right lower lobe collapse because you don't have the right heart border and you don't have the right diaphragm there. And on the lateral, can you appreciate how before I was telling you about the diaphragm that stops halfway, that must be the left? Well, if that's the diaphragm that stops halfway, that's the left. Then where is the diaphragm on the right side? You don't see that diaphragm on the right side, so it must be a right lower lobe collapse. So what's happened is the right lower lobe has collapsed. It has now silhouetted with the right diaphragm, causing this hazy appearance. So the right diaphragm will be here somewhere, just not visible on this chest x-ray. And just very quickly, this is the silhouette sign for the left side. So it's not as exciting as the other side because there's only two lobes, and because the left side, funnily enough, doesn't really attach a lot to the heart. It's really the upper lobe that collapses onto itself, like here, and then the left lower lobe. Interestingly enough, usually the left upper lobe collapses up, and the left lower lobe usually collapses downwards. So, if you have a look here, this is a left upper lobe collapse because you don't have the left heart border, and you see this really hazy appearance. This hazy appearance is consolidation, and consolidation, again in this case, has similar density to the left heart border. So that's why this particular chest x-ray is an example of a left upper lobe collapse. On the lateral, it's very obvious that is the oblique fissure. That is part of the left upper lobe that has collapsed. And so you see this beautiful appearance here. Very striking. Left lower lobe pathology, hopefully you can appreciate that you can still see some of the left cardiac border here. Because you can see some of the left cardiac border contrasting with this density increase, you can call it a left lower lobe collapse, because usually a left lower lobe collapse will sit at the back here and doesn't silhouette with the heart. Now, hopefully you've noticed that throughout the last couple of minutes, I've kept calling this as collapse. And another word for collapse is often atelectasis. And atelectasis is lung collapse. And lung collapse can be due to consolidation. So the word consolidation and atelectasis often get a little bit confused or a little bit muddled. But if you think about it in simple terms, consolidation is essentially a term that is used to describe the alveoli, the actual air exchange compartments of a lung being filled with pus, fluid, transudate, blood, those kind of things. So because of that, you often have these hazy appearances throughout the lung, but you can still see that the lung is functional, because a sign of consolidation is air bronchograms. However, if you start seeing lots of white haziness, lots of all these mucky stuff, but then you don't really see these other indirect signs of consolidation, like air bronchograms, those kind of things, then you can start calling it collapse, because a collapse also looks like consolidation. And I think the reason why students get confused is because the two appearances are very similar on X-ray, but they are morphology-wise very different. This is a question for you guys. Have a think about it, and hopefully I've rambled on enough that you guys have had a chance to look at it. Think about what you see here. Obviously, that there's pathology on this side here. So the right lobe, so then you should immediately go, all right, right lobe, so right lung, there must be 3 lobes, so it must be an upper, middle, and lower, and hopefully just by doing that, you go, all right, this pathology is very centralized in the chest. It's right next to the right cardiac border. In fact, I don't see the right cardiac border. I see a little bit of the diaphragm there, but not as well as I should. That is alarm bells for right middle lobe collapse. You see all of these spiraling, radiating reticular patterns. No air bronchograms through this particular opacity, density. So this is probably going to be a right middle lobe collapse. And you can see there that the right diaphragm isn't as indifferent to the left. And so because of that, we know that it must be the right middle lobe, because if it was the right lower lobe, that diaphragm wouldn't be visible to us. And hopefully you can appreciate that nice triangular shape as well.